from Dr. Kurt McCammon, who is talk about radical prostatectomy incontinence, urinary incontinence, which is the first session that we'll have a CME credit, and we hope we'll go from now and start having CME credit for all the coming session. Before he start, I would like to invite you all to fill the survey that we will receive. You already received it, about the telemedicine from our colleague, so that we have data to prepare the next the September session of telemedicine, another webinar. So welcome, Dr. Kurt McCammon, and please, as usual, we're happy to listen to you.
Mohammed, thank you. And thanks, PAUSA, thanks, Katie and IVU. I think this has been a wonderful collaboration, and it's something that I think everybody benefits from. Unfortunately, obviously, we don't have the opportunity to meet in person like maybe in the past, but hopefully sometime in the future. So Mohammed asked me to talk about post-prostatectomy incontinence. And what I'm going to try to do is give a little overview. I have a couple videos that I'll show and then answer any questions. I initially, just again want to thank, he's probably not on this, but Dr. Danzo and actually Dr. Gay, two big leaders in PAUSA and people who have mentored me and helped me as I've moved forward and continue to work with my friends in Africa and all over. So I do want to honor them. So, and if there's any questions, please, people can interrupt me or we can answer it at the end. But I think it's very interesting. In the United States, you know, it's really kind of interesting how we define incontinence after prostate cancer treatment. And there's a lot of different ways of looking at it. If you ask patients, if you send questionnaires to patients, about 40% at least will have stress incontinence after a prostatectomy. If you ask a urologist, we'll say somewhere between 0 and 10%. And it's very funny because, you know, I'm very fortunate. I've done a number of these surgeries, and my partners in Norfolk will tell me when I give a talk, make sure you tell people these are not all from Norfolk, that, you know, we don't have any incontinence in Norfolk. And every time when I've been in Africa and we've talked about incontinence, most of the people doing prostate cancer surgery will say, well, I don't get incontinence. That's not true. Unfortunately, everybody does. And it's not a problem with the surgeon. It's a surgery that's going to have issues. And we just need to be able to understand that so we can ask our patients, how can we take care of them and how can we make them better? The reason why it's important to do that, though, is this truly affects people's quality of life. So this was a survey, it was done years ago, obviously, but 26% of patients with moderate or have moderate to severe limitation of their activity. 36%, it affects their lifestyle. 45% of patients, it affects their confidence. I tell a story of a patient of mine who had a prostatectomy, and he was pretty incontinent, 5 pads a day. And he was depressed, he was overweight, he came in poorly dressed, and he was poorly shaved. And we fixed his incontinence, and 6 months later, he came in, he lost 25, 30 pounds. He actually came in well shaved, well groomed. It completely changed his outlook on life. And so I understand this is not affecting cancer control, but it does affect the patient's ideas on life and aspects. So it is something that we should address, and if we can, we should try to treat it. This was a study that we did in Norfolk, and what we did was we looked at about 1,000 men online, and we asked them, you know, how does incontinence affect your daily life? And as you can see, 50% of people would try anything to cure their incontinence. Over 50%, never a day goes by. It's a major impact on quality of life. 40%, it affects their relationships. This is not just a problem for the husband, it's a problem for the husband and the wife. You know, they're the one cleaning the clothes, changing it, doing the laundry. So it does affect their relationship. It also, obviously, erectile dysfunction is associated with prostatectomy. And even if they're having erections, most men are not interested in having intercourse if they're going to be totally incontinent. So it does affect the relationship as well. It's also very expensive. Again, this is an older study, but 26 billion, not million, but $26 billion was spent in 1995 just on taking care of incontinence. Unfortunately, only $600 million was spent on surgical treatment. So 11 billion was spent on buying diapers, doing laundry, changing clothes. It's incredible to me that only 600 million was spent to treat it, but so much was spent for people just to kind of hide it instead of actually seeking care. And men were shown to be less likely to seek treatment. And as we all know, I mean, some of our male patients are some of the worst because, you know, they don't want to talk about things. They won't come in to see the doctor. And so I think it's important that we as the physicians address this and ask our patients. So this was a big, something that was felt to be important in the AUA in 2019 had a practice guideline. So a guideline came out. I was honored to be involved, and this is the panel members. And the rationale for doing it was, it's a problem that we as urologists cause. And so if we cause a problem, we should probably come up with a treatment. There are risk factors that are known, but they're not universally, not everybody knows them. The management, unfortunately, varies very greatly in the United States, and I'll show you a slide about that. And there is a large body of evidence, so we felt that we could generate a good guideline. The AUA felt they could generate a good guideline. And so what the guideline does is it gives us a good evaluation of our patients. It talks about the risk factors, talks about the assessment of the patient, and then it talks a stepwise approach to management. Now, I'm not going to go through all this because we're not going to have time, and it's probably not, all of it is not relevant, but we're going to go through a little bit, and then we're going to do, we'll do some videos to show kind of the surgical procedures. But what questions do I want to ask? So my patients, when they come in, I want to know the number of pads. Are they able to start and stop their stream? Do they leak at night? Is it really stress incontinence or is it urge? In the United States, so many of our patients now are getting adjuvant radiation, after because of a recurrent PSA. And if they've had radiation, obviously that makes the risk of incontinence worse. How far after surgery are they? Did they have a nerve sparing procedure? Again, frequency and urgency, nocturia. And then I always address erectile dysfunction because I want to be the one at least bring it up, because if they are uncomfortable talking about it, I want to make sure that we have an open conversation. So what's the etiology? So I break it down into 3 different factors. There's patient factors, that's age. Obviously men over the age of 65, for sure 70. I recently saw a 79-year-old man who had a prostatectomy. I was amazed that, number one, someone would do that. But number 2, he was wearing 8 diapers a day. Well, age is a huge factor in this. The BMI, the prostate volume, there's a good MRI study showing decreased membranous urethral length will increase the risk, and obviously a previous TUR. Those will increase our patient's risk of having incontinence. Are there surgery factors? Of course. So nerve sparing obviously decreases the risk. So if you do a nerve sparing, incontinence is less. The surgeon experience is a component of this. So people who do more of these surgeries have less incontinence. And then membranous urethral length, again, sparing the bladder neck and membranous urethra actually can decrease incontinence. And then there's postoperative factors. If the patient gets a stricture, our risk of incontinence is significantly higher. But they also, if they have had radiation, obviously that's higher as well. So the initial evaluation, so obviously you want to do a good history and physical. You want to do a PVR and a UA, and those were part of the guidelines. Avoiding diarrhea is something that we all tell everybody to do in quality of life surveys. I'll be honest, I don't know if many of us do it. It's one of those things where you need to do avoiding diarrhea, but even if I do them, half the time I don't even look at them when I talk to the patient. A cystoscopy is something that we'll talk about in a second, as well as urodynamics, and then pad weights. So obviously most of our patients are getting a cystoscopy, but I'm not sure they're always really needed. The other thing is when we first started doing a lot of incontinence treatment in men, we would have them bring in all of their pads for a day and we would weigh them and determine how many grams they leaked. Vic Nitti did this great study where he looked at the number of pads they used, the type of pads they used, how wet they were, and does this affect their quality of life? And what he showed was you don't need to do a 24-hour pad test. A number of pads correlates to how bad their severity is. So the way we look at it in Norfolk is 1 or 2 pads is probably mild incontinence. 3 to 5 pads is probably more moderate, and then greater than 5 pads is probably severe. And that's kind of how Vic, if you look at his chart, kind of broke things down. What about urodynamics? So this was a study that one of our residents did, Jack Zuckerman, and what he looked at was urodynamics after prostate cancer, da Vinci prostatectomy versus a radical prostatectomy. And I think the interesting thing on this, and something that we need to remember when we're talking to our patients about treatment, there's 2 different things. So overactivity, as you see, 25 to 40% of men will have overactive bladders associated with their stress incontinence. So this could be an educational opportunity to tell our patients, well, I may make your leakage when you laugh, cough, and sneeze better, but you're still gonna have an overactive bladder. The other thing is one of the papers we recently published showed that overactivity decreases the efficacy of male slings. The other thing I think is important is to choose for underactivity. So 20% of men, their bladder doesn't function after prostate cancer surgery. So maybe they won't respond well to a sling if they're unable to empty. So the reasons that we would do a cystoscopy is to rule out stricture, look at the membranous urethral length, and if they've had an open prostatectomy, again, rule out stricture and look at their external sphincter. And if you look at the guidelines, guideline 14 and 15 recommend doing a cystoscopy for sure. And then they say you can perform a urodynamic study. You don't have to perform a urodynamics. I know in your setting, doing urodynamics is not as easy. And so if you are going to treat these patients, the cystoscopy preoperatively and a good history is what you need to do. So what about when can you treat these patients? So this was a study that was done by one of our residents, Liza Rogers. So we've always been taught that you have to wait 12 months to do surgery for incontinence. And I have a lot of men who show up significant incontinence at 3, even to 6 months and want to have treatment. And I've always made them wait. So we actually did a study looking at our quality of life database. And what we found was that if you are leaking more than 3 pads at 3 months, your chance of getting better is not, you're going to continue to remain incontinent. And those patients, I think if they're at 6 months, I'm okay with offering them treatment. And if you look at the AUA guidelines, the AUA guidelines does say you can start offering surgical treatment at 6 months if you decide you wanted to. So there you go. So what are our treatment options? So we have supportive devices, clamps, catheters, pads, physical therapy. There's currently no medication for overactive bladder, as we all know. People have tried Cymbalta, and actually there is some data that shows that it works, but it's not used in the United States. There's injectable agents, and then there's surgical options. Here are some of the supportive devices I could find online. And I'll be honest, I've had patients coming in with all of these things. And, you know, I can't imagine walking around with this device or this device. I really can't imagine walking around with a Cunningham clamp on all day. We have had 2 patients who actually amputated their penis with Cunningham clamps. Now, they weren't prostate cancer patients. They were neurogenic patients. So they had loss of sensation, but they actually came in with almost a complete penectomy. One of them, I removed the penis in the office because there was no tissue left, just a little bridge of tissue. So these can be very dangerous for patients to use. I really try to talk people out of this. So if you look at a mild incontinence patient, the AUA guidelines would say for first and foremost, all patients should undergo pelvic floor training. And in my center, I'm very lucky. You know, I understand how different our centers are, but I have 7 physical therapists that actually are about 25 feet down the road from me. So or down the office from me. So my patients would go see them immediately after surgery and sometimes even before surgery. And what they'll do is they'll educate our patients. They'll teach them how to do the pelvic floor exercises. They do it in a kind of a quiet setting, although this doesn't look that quiet. But they'll teach them how to do the exercises. If the incontinence continues to, persist, and it's been stable for 6 months or a year, then we need to talk about other options. The other thing is, if you look at pelvic floor, this is a meta-analysis that looked at a number of studies on pelvic floor therapy, and what it does is it increases the time to continence, but at 12 months, the success rate in patients who don't use physical therapy, who do use physical therapy, is the same. So you don't necessarily have to, because the patients are going to get there at 12 months anyways, as long as they're doing some type of exercises. But they do better if you they'll do quicker. They'll get their continence back quicker if you do physical therapy beforehand. So this was, I mentioned I would talk about a study that talks about the use of the different surgeries. So we found this quite interesting when we were putting together the guidelines. So this top line is injectables. The light blue line is the artificial urinary sphincter. The dark line is slings, and then sphincter revisions and sling revisions. So as you can see, the most commonly done surgery in the United States is injectables. Well, in the guidelines, we recommend using injectables. Success rates are somewhere between 10 and 20% at best, and success is defined as an improvement, not a cure. So it rarely works, and actually it can affect outcomes of other surgeries. So this was probably one of the main reasons this guideline was developed, because of the fact that more men are undergoing procedures that don't work by 3 to 4-fold difference in number of procedures done. The injectables that we had available were Contigen, but that's no longer available. Durasphere, which is also no longer available. Coaptite and Macroplastique are still available, but again, success rates are pretty poor. Now I'm going to tell you that, but then, so if you look at the guidelines, the patients with incontinence after treatment should be counseled that the efficacy is low and cure rate is extremely rare, so it was recommended against. Now I tell you that, and then here's it's not a publication, but Amanda Chung, who was one of our fellow a couple years ago, actually I think came to Zimbabwe for the PAUSA meeting. We have pretty good data if you do it after a sling. So if the patients have improvement but they're not cured, we have about a 90% improvement. And those patients, this lasts for greater than 2 years. So it is an option in somebody who's had a sling. So again, mild incontinence, again, a secondary recommendation if they don't respond to physical therapy is surgical options. And the surgical options are a sling, a sphincter, or some people talk about an adjustable balloon, which we're not going to go into today, but the guidelines recommend it again. So that's actually something that we were not very strong proponents of. The guidelines said that male sling should be considered as a treatment option for mild to moderate incontinence. So what I thought I would do is show a video on the male sling. I'm going to skip through parts of it, and I'm going to try to, how am I going to mute this? I'm not sure I'm going to be able to mute this. So I'm going to over talk it a little bit. So we're going to make a midline incision. I'll let me talk. So now we're coming down on the sponge, using electrocautery to go through the muscle. I'm going to skip through it so we have time at the end, but I'm going to kind of
until now, it's the same dissection as if you would do urethroplasty.
Correct. Except this is an easier dissection because there's no scar tissue from the urethral stricture. So once we finish the dissection, we'll find the pubic rami, which I'm pointing at here. And we're going to, so there's no risk of injuring the corporal bodies doing this. So we're going to pass our needle. It's a transobturator sling that will pass just like we would on a female. We're marking out the abductor longus and the bone. And so the needle is passed through this incision and then out through the perineal incision. So at this point, we'll attach the mesh to the sling and then bring that back through. And then we'll do the same on the opposite side. So now the mesh will be it'll be fixed to the corpus spongiosum. I use 4 sutures, 2 proximal and 2 distal. So once it's fixed to there, just like this, we'll do a cystoscopy, and then we'll confirm tension as we pull. So we'll pull up.
And you make it real tight.
You pull this really tight, yes. And then as you'll see on the cystoscopy, you'll see a complete coaptation or closure of the urethra. This is a sling that can be done with, so in the United States, there are slings that are made specifically for men. In all honesty, they're really no different than the female slings. And I have used the female slings on patients. I think we did one in Senegal in the past, and I know we've done them in Trinidad and other places that work really well to fix incontinence. So I think you can use the female sling in these male patients in a transobturator way. But you see nice coaptation of the urethra at this point, and so it's completely closed. The rest of the surgery is just showing the closure. So I'm going to skip that. I can share this slide set with the videos. There's also a video on a sphincter we'll show in a few minutes. So I'm happy to share these with anybody. Just have to send me a couple reminders because sometimes I forget. When you look at the long-term success rate of the male slings, this was a paper that one of our, Michael Chua, who actually was at PAUSA in Côte d'Ivoire, he published looking at about 215 patients. We had a follow-up of almost 5 years. Overall, we had about a 70% success rate. 45% were dry, and then another 25% were significantly improved. But what he did, which was I think very good, is he broke it down on severity. And when you look at the severity, 85% of our mild patients did very well, and 72% of our moderate patients did okay. And so this is sling procedures are good procedures for mild to moderate. Once it gets above that, we really don't recommend doing the slings. And then urge incontinence was the only variable that actually affected long-term outcome. And so if they had urge incontinence pre-op, they had a good chance of the sling not working, which is why the urodynamics may be beneficial if you couldn't discern that in your history from the patient. So then when we look at the guidelines, guideline 17 says artificial urinary sphincter should be considered for patients with bothersome stress urinary incontinence in all patients. So the AUS, the artificial urinary sphincter 800, is the gold standard. It's the procedure that's been around the longest. It's been around for over 50 years. It's had minimal changes actually since 1986. There's been mild variation or changes of the device. It works that well. And so it is an operation I think you could consider. Obviously, the issues for you are cost, because the device in the United States costs about $15,000. Insurance pays for it in the United States, but I do understand that's not possible in most places. This is the device. So there's a pressurized balloon reservoir, there's a cuff, and there's a pump. The pump does have a deactivation button that you can turn off. So if the patient's unable to use it, if he has a stroke, he develops Parkinson's and he can't squeeze it, then you could obviously just deactivate it and he would go back to being incontinent. The pressurized balloon reservoir has different pressures, but we usually use 6170. And then the cuff comes in different sizes, obviously, because men have different anatomy. It's important though, and I left this slide in there just because it's really important to have the right size. If you have the cuff too big, they're going to remain incontinent. If you have it too small, they're going to leak. And so this is probably the most important thing. If you ever do an artificial urinary sphincter, make sure you leave it a little loose, but not too loose, if that makes sense. How it works, so the device is implanted, and I have a video to show the surgery in a second, but the device is implanted, and it's activated at 6 weeks. So for the first 6 weeks, the patient will leak. And then in the office, you activate it by just squeezing the pump. So it's very simple. And then the cuff is always tight. So the cuff is always closing the urethra. When the patient wants to void, he will pump his scrotum. This will transfer the saline out of the cuff through the pump into this pressurized balloon reservoir. This will allow our patient to void. And then after about 60 seconds, this pressurized balloon reservoir will push the fluid back into the cuff and he'll be continent again. So he just has to squeeze it 2 or 3 times to urinate and then he's done. It's a very ingenious kind of product and it's all about the reservoir. So the reservoir is dipped in silicone and that determines the pressures, which is how it works. So this is actually a video by a friend of mine, Greg Bales. And again, I'm gonna skip through parts of it so we don't have to spend a lot of time. Actually, I'm going to be done quicker than I thought. So it's a similar dissection as the previous surgery. One of the differences, you don't need to mobilize the urethra as much inferiorly. But you're going to get all the way around the urethra at this point. sorry about that. I'm not sure what happened. So now he's making an incision in the abdomen, and what he's going to do is place a reservoir for the pressurized balloon reservoir. So this is really important. There have been times, I had a good friend of mine who did a sphincter recently, and they lived kind of close, and it never worked, and the patient got referred to me, and he never filled the balloon, so the device never worked for the patient. So it's really important, obviously, that the surgery goes well, but you got to make sure that you do all the appropriate things. It was quite upsetting to the patient, obviously. That does require another operation. You just can't fill this through percutaneously. So he did have to go to the operating room to have to check to make sure there wasn't a hole, but then to also fill the device. So once the device in the tubing is passed, then we'll make a connection. So American Medical System has this called a Quick Connect system, which is a little device that allows us to put the tubing together. When I was in training 100 years ago, whoa, sorry about that. We actually had to tie these to put these together. So it did take quite some time to do that. But now we have this Quick Connect system that allows us to put them together. Again, you want to do it under, and there's the picture of things. At this point, once it's all put together, you'll close your incisions. You'll then deactivate it. You'll make sure it cycles. You'll deactivate it. We leave a Foley catheter overnight, and that's taken out the next morning. They go home, and in 6 weeks, we see them back in the office, and we activate it. Now, the wonderful thing about the sphincter, as I mentioned, this truly is a device that is the gold standard. It was developed in the 70s, and it really has had minimal changes since 1986. So it's actually stood the test of time. The problem, though, is it's not perfect. So as you can see here, here's some older studies. So 90% of patients at 10 years are still continent. Just for you to understand, continence is described as 1 pad a day or less. So they're not completely dry. The other thing is you see is 66% of them have device survival. So this is a product that your patients, if they have this, are going to have a revision at some point in their life. They're either going to need to have it replaced because the incontinence comes back, because you'll get atrophy or thinning of the corpus spongiosum. You could get an infection, which is about 1 or 2%. It could erode through the urethra. You know, if someone tries to put a catheter in, so it's very important. Our patients either wear a medical alert bracelet, or they have a card, or they know that no catheter can be placed without a urologist placing it. If you do, it'll tear the urethra if they don't activate it. And then the device could break. So I tell my patients all the time, this is a product that you're going to come back to me. You know, if you live long enough and you want to have it changed, you're going to be coming back, and we're going to do another operation at some point. But again, success rates are very good. Satisfaction with patients are very high. It's also really nice when you look at something, you know, it's how many times have you read a paper where somebody says they have 100 or 95% success rate, and you try the operation and it doesn't work? Well, it's really nice that this operation has been done by hundreds of people and has been published so many times, and the success rates are almost always the same, 85 to 95%. So it is an operation that's trainable, teachable, and patients do very well. And again, is the quality of life operation and cost effectiveness. It's actually been shown to be more cost effective than injectables. So how do I treat incontinent patients? So first and foremost, I ask my patients. I think it's really important. Again, our partners are prostatectomists. I know you'll probably be both the person doing the prostate surgery and the surgeon talking to them about their incontinence, but it's important to address that, because although you might have saved their life by doing the prostatectomy, they still could have complications. And I think quality of life is very important. And Mohammed's heard me say this before. I think there are quantity of life surgeons and quality of life surgeons, and I'm for sure a quality of life surgeon. And I think that's just as important as quality of life or quantity of life. So the first 6 to 12 months, we'll try physical therapy. If their incontinence is more severe, I will offer them surgery between 6 and 12 months if they're very bothered by it, if it's truly limiting them. But they need to be wearing about 4 or 5 pads a day. What I require is they see our physical therapist. Our physical therapist tells me they're doing their exercises and they're trying, they're just not getting better. If it's greater than 12 months, we'll offer a male sling, because I think it's probably just as reliable, maybe not as high of success rates, but patients like the fact that they don't have to use a pump in their scrotum. They know they're not coming back for another operation at some point. And if it works, it appears to last. I saw a patient probably a month or 2 ago who I did a sling on in 2008, and he's still dry. So he's gone 12 years. Now, he was only 1 pad a day. So, I mean, he was the ideal candidate, but it's worked very well. If it's more moderate to severe, we could try a sphincter. And then for the difficult patients, obviously transcorporal and AUS, but those are things that are probably down the road or more of a realm. Hopefully this has been helpful. You know, and Mohammed asked for this. I'm like, oh, I know we're not doing a lot of this. I think what I hope people take from this is, number one, if you have any questions about male incontinence, please don't ever hesitate to email me. I'm on all the PAUSA emails, so my email is there, and I'm happy to talk to you about it. But truly to address it with the patients, to talk to them, to make sure that, you know, they know you're on their side. I do want to thank, here's some pictures from previous PAUSA and EuroDAC meetings, some really good friends, and it reminds me of some good, great memories. And here is the up-and-coming urethral reconstruction star on your continent. Here's Mohammed doing his first infrapubectomy, probably 2 years ago now. It's been so long.
Yeah.
But I'm truly happy to take any questions. I've got a lot more slides, but I wanted to have some time at the end so we could have time for questions. So I'll stop sharing my screen. I'm happy to answer any question, or, and if people want the slides, email me. If it takes me 2 or 3 times, just email me again. I promise you I will send it, or Mohammed can share my WhatsApp with you as well.
Thank you. Nice talk and very illustrative video as well. So it's now the question time, and I will start with one question regarding the artificial sphincter. You have to revise the artificial sphincter. Which component is the hardest? Is usually the reservoir, the pump, or do you need to revise the cuff? In which case you might face some fibrosis.
Yeah, so that's a great question, Mohammed. And it's interesting. So again, I'm in a different situation than other places. So in the United States, after 2 or 3 years, we revise the whole thing. So we take everything out and we put a new one in. The more difficult one, most people find, so the cuff is actually not that hard. It's actually pretty easy to do. You come down on the capsule, you open it up, and the cuff comes out. We usually place the cuff in a different spot, just because I think I want more healthy spongiosum. But the cuff isn't the hardest. It's actually sometimes hard to get the reservoir out. The reason I think that is because it's deeper, into the perivesical space, and so sometimes that's difficult to get out. If it's in the first, so if you think about revisions, initially you'll have to revise if the patient's still leaking and severely leaking after the first, 3 months, or you revise the cuff. But that's pretty rare. I would say that probably has happened to me once. If it's too tight, which has happened to me twice, you take it back and then put a slightly bigger cuff in. But those are really the revisions. Long term, we do a lot of revisions and explant sphincters and new sphincters, but that's for men who are, 6, 12 years out and their sponge has just gotten atrophic, and you just take everything out and put another one in.
Thank you. We have a question from Dr. Lagelus, who, by the way, say thank you for the great talk. He's asking if you have any experience with the new AUS, the Victor.
I do not. So it's not currently available in the United States. So unfortunately, I do not. There are a couple new products that were coming out, and I don't know which company is making this, so I don't think I can comment. There was one that was coming out that had a higher risk of complications, and so than the current sphincter, but it was a lot cheaper. So actually, John, I'll look this up just to see, because I'll be honest, I don't know which one this is. So I'll look it up and try to get an opinion on it for you. Send you an email or something.
I can see two people who are interested in, who are involved in reconstruction. Number one is Dr. Igor Vaz. Dr. Vaz, do you want to make a comment?
Hi, Kurt. Hi, everybody. Thank you. Thank you for this nice presentation.
Great seeing you, Igor. I hope you're doing well.
Yes. Look, if you decided to make a sling and then you decided to move for a artificial sphincter, there is any problem?
Yeah, there's really no disadvantage.
It doesn't work.
Yeah, so what we usually do is leave the sling in place, and then we just put a sphincter a little bit further distal to it, because the sling is going to be very proximal. It's hard to remove because it actually truly pulls the urethra into the pelvis almost. And so we would just, we would just put a sphincter just distal to that. And there's been, I think, one paper published showing that the success rate in the sphincters were the same as if it was a virgin patient. So I don't think there's any significant issues.
Thank you. Thank you.
We have Dr. Medina who is asking about using autologous material like fascia seem to give good results in female incontinence after obstetric fistula. Does that work for male?
So Medina, hi, how are you? It's good to hear from you. I don't know. So I have done a few. What I've done it in Kenya, and I did it one other one, in Trinidad, where I did a fascia lata. So I harvested fascia lata for the male, and then I did a sling. So I've done two. Initially, the patients did well, but unfortunately, I don't have long-term follow-up, so I don't want to tell you that they're continuing to do well. But they did well initially, so I don't know. I mean, 3 months after surgery, the email I got was, patient is very happy and doing well. my email 6 months later, I never got returned. So I don't know if they continue to do well.
Okay, we have a question from Dr. Shura asking about any experience with double coughing.
Alan, good to hear from you. I hope your family is doing well, and hopefully your daughter's in the States, and not hopefully she's in the States, but hopefully you're doing okay at school. So a double cuff's it's a really good question. So back in the 90s, there was a big push for more severe patients to do 2 cuffs at the same time, with the thought that increasing resistance along the urethra would decrease incontinence. And the first couple papers showed that it worked actually pretty well. But there have been 2 papers now since that with larger experience. One was a multi-center study. And those actually showed, actually both were multi-center, sorry. They both showed continence rates were no different than a single cuff, but complication rates were higher. And so I will tell you that I've only done 1 double cuff in my career. I really don't want to do them. And the only reason I did it was my good friend Jaspreet Sandhu sent the patient to me from New York for a double cuff, and the patient came adamant that that's what he was going to do. I can tell you that he didn't do well long term. He lives in New York, so I haven't seen him, but I know he had trouble with it. So currently, most people in the United States will not do a double cuff, although there are still a few people out there that will.
Thanks, good.
Thank you. Dr. Mbasi, do you want to make some comment? I know you also do many urethroplasty in Cameroon. Dr. Mbasi, can you unmute yourself? Okay, we have a question here from Dr.
Est-ce que vous m'entendez?
Oui, oui.
Yes. I don't have any comment to do. I just want to congratulate and to thank Dr. Kurt, and I hope that he will come to Cameroon after coronavirus.
I promise I will. I promise. I told you I would come, and I will. It just, unfortunately, really kind of messed our plans up when we were supposed to come in April.
Thank you very much. Thank you.
Yes.
Okay, there is a question from Dr. Lawal in Nigeria asking about how effective is sling and artificial sphincter in patients with previous radiotherapy.
Well, hey, it's good to see you. I hope you are all doing well. Actually, if you look at the data, sling procedures are probably not effective for radiated patients. You could possibly consider doing a sling in someone who has mild incontinence, and that may be a reasonable option. When I say mild, I mean maybe 1 pad a day. But the artificial urinary sphincter actually does very well. Success rates are actually equal to patients who have not had radiation. But what it appears is that the revision rates are probably a little bit sooner. So what I tell my non-radiated patients is you're going to need a revision probably about 8 to 12 years. I tell my radiated patients you'll probably need a revision 5 to 8 years. So they do, the incontinence does come back a little bit quicker, probably because of the loss of blood supply to the corpus spongiosum, and so increasing atrophy. But the initial success rates are actually very similar. And so all of our patients, if they wear more than 2 pads and they want treatment, get a sphincter.
Great. Any question from the audience? You can, if you have a question, you can unmute yourself.
While we're waiting for questions, does anybody have any suggestions? Should I ask that, Mohammed, about for the next talk?
Yeah, you can also make a suggestion for the next webinar in 2 weeks. We have here Dr. Shingai from South Africa. I know he is involved in many studies in prostate cancer. We already had 1 session on prostate cancer, mostly devoted to diagnosis and staging, but I know we have many people out there in the US who will be happy to do a presentation on prostate cancer or any other cancer. It's been a while we haven't talked about cancer. Any suggestion for that?
Yeah, hi guys.
Hey,
Great talk. Hi, Kurt. How you doing, bro?
Good.
Yeah, no, great talk as usual. Yeah, I think that we're about to get involved in some studies on prostate cancer and the incontinence issues. So I really was excited by what you said. So I haven't really got a suggestion. I wanted to hear exactly what you've said because we're actually going to be talking about that at our conference. We've got a virtual registrars conference coming up.
Oh, great.
So I will think about it and then I'll get back to you. I think what I might do is because I'm going to talk to Mohammed tomorrow. There's something else I wanted to talk about, but maybe we can start. Maybe you guys might get involved with our registrars conference. It's going to be in November, and we've got a lot of different topics, and one of them is going to be exactly what you've talked about.
Okay. But as you know, of course, I'm happy to be help in any way I can. So just send me an email and you know, we can do it during the conference. I can do it anytime you like, you know, whatever. We can do cases. I know John and I have talked, and I think it's my fault right now. I haven't followed up with John about scheduling something. So yeah, I'm happy to, it's completely my fault. But I'm completely happy to do whatever I can to help, of course.
I think if there is any suggestion,
perfect.
Session,
okay.
You can send email to myself, Shingai can also, like it's about suggesting any topic for the next session in 2 weeks. Yeah. Yeah. Any other thought or remark? Yeah. Just to remind you also, for all of us to fill the survey about telemedicine that will give us data that can be used in a webinar that is scheduled sometimes in September. You'll hear more about that. It's with the International Society of Telemedicine and Telehealth. So one more word from Kurt.
I just want to, I mean, obviously, thanks again. I really appreciate the friendship and everything you've done, Mohammed, and everything going on. I hope you all stay safe. And I hope we can all get together sometime soon. I hope it's sooner than it's probably going to be, but hopefully soon. And don't forget to ask your patients if they're incontinent after you do their surgery, because nobody's perfect and it happens to everybody. So thanks everybody for joining. I hope everybody stays safe, and I look forward to seeing everybody in person.
Okay. Thank you. Thank you. Thank you, everybody, and see you soon. Bye-bye.
Thank you. Thank you.
Bye.
Thank you, Mohammed.
Bye.
Bye-bye. Thank you, Mohammed.
Thanks, Kurt.
Hey, Katie.
That was great. Thank you so much.
Thank you. We'll